Next, the chair calls Dr. Diane Earle with Kool Smiles.
I'll have to change my wording to good evening as well.
Yeah, sorry.
Madam Chair and members of the committee, good evening, and thank you for inviting me to talk with you about a very important issue regarding children's oral health care in the state of Texas. My name is Dr. Diane Earle, and I am here to testify before you in the capacity as a dentist, licensed in the state of Texas for almost 30 years, and as a senior regional dental director for Kool Smiles. Since 2007, Kool Smiles has been meeting the dental health needs of the underserved in Texas and has grown to 38 offices, 85 dentists, and nearly 800 dental professionals. Let's remind ourselves visually why we're here today. I believe each of you all may have received a picture that shows why we're here today, and that's to take care of the children here in the state of Texas that have decay as such. Tooth decay is the single most common childhood disease, more so than asthma, and it is on the rise for the first time in 40 years. Low-income children are more than twice as likely to have cavities. They are far less likely to have means or access to necessary dental treatment. Poor dental care results in additional missed school days for these children and lost time at work for their parents. Only about half of the children eligible for this service receive care. Texas has rightfully responded to this health crisis by taking steps to improve access for this underserved population. Responding to the great need, a new model has emerged in dentistry, the group practice, partnered with the Dental Service Organization, or DSO. Kool Smiles is an example of this innovative model. At Kool Smiles, all dental offices are owned by dentists, and all clinical and patient treatment decisions are made by the treating dentist. The DSO supporting Kool Smiles is NCDR LLC, which is a practice management company. As a licensed dentist practicing in Texas, I am an advocate of the DSO support model, as this structure frees me to focus on what I do best, providing high-quality dental care to my patients and spending more time with them. Our DSO provides the business expertise to manage the day-to-day operations of the offices. Although this business model is relatively new in dentistry, it has been in existence for many years in other areas of health care, and its effectiveness is proven. Partnership with the DSO allows us to treat these patients that most dental practices do not expect. The business management team focuses on the non-clinical and administrative functions, such as electronic health records, so that my colleagues and I can focus on taking care of our patients. I can only emphasize that my message here says, nobody tells our dentists how to treat our patients. Medical necessity dictates treatment. Nobody tells our dentists how to treat our patients. Medical necessity dictates treatment. Now I want to talk to you about my passion, which is quality of care. I have practiced as an independent dentist in my own practice. I've also practiced in the group practice environment, and now I practice at the clinical leadership role with Kool Smiles. I lead an experienced and diversely skilled clinical leadership team that provides peer-to-peer mentorship as well as clinical guidance to our dentists. Our dentists thrive because they are supported by their peers in their clinical and diagnostic skills. In all my years, I can say unequivocally that Kool Smiles has the most comprehensive, state-of-the-art programs and protocols in place that monitor and help ensure compliance and quality of care. We perform 8, and I'll say it again for emphasis, 8 different types of clinical audits to measure medical necessity and quality of care. Internal and external auditors track adherence, and that's what we think makes us superior. Now let's talk about the interest of the public. We are a great public-private partnership and are fiercely protective of the taxpayer dollar. Improving the oral health of children routinely lowers the amount of operative care needed. Over a 4-year period, a typical Kool Smiles patient's need for dental services decreases by 28%. And our patients come back. I'm proud that 74% of our patients return for subsequent appointments. Preventative care saves taxpayer dollars by reducing the need for later, more extensive treatment. That means fewer emergency room visits. I know you have been supplied with copies of a remarkable recent study that comes from economist Art Laffer. Notably, DSO clinics billed less per patient for certain common procedures. As to Kool Smiles, average cost per patient per year, $345, and for other DSO clinics, $483. For non-DSO practices, they bill $711. If you just look at those photos again, our patients are not like the patients in typical dental practices. Poor diet, poverty, and parents uninformed about the need for dental help creates a scenario where kids come into our clinics with dire situations and with dire health problems. We care about these kids, and we serve these kids. Many of our dentists typically come from backgrounds where the underserved has been a big part of their lives. I can't emphasize enough the need for continued support of HHSC's First Dental Home program, of which Kool Smiles is a proud participant. And let's maintain a commitment to oral health education. Preventative action is rewarded over and over in long-term savings and, most importantly, in the transformation of lives of our children. I look forward to working with you, and I'll be glad to answer any questions that you may have at this time or later in our panel.
Yes, Vice Chair Neistat.
I'm confused again.
Okay.
What exactly is a DSO clinic?
A DSO is it's a dental service organization that supports, for Kool Smiles, that supports the clinical division. So in other words, Kool Smiles is owned by dentists. All of our offices are owned by dentists, but the DSO in our model supports that division. All clinical care, all direction of clinical care, all medically necessary treatment are made by the treating dentist. The DSO provides the business support for our offices, such as billing, electronic health records, HR services, things like that. I can only emphasize, and I understand that there needs to be a clear distinction between the business support services and the clinical services. And I can say for sure and certain we have processes in place to ensure that the doctors are making those clinical decisions. There's nobody coming from the DSO or anybody else that's telling the doctors how to treat our patients. Those decisions are clearly made by the treating dentist.
Well, I have a suggestion.
Okay.
I can understand you saying I appreciate the DSO support model, and I can understand you saying regarding the benefits of the DSO business model, but when you make a reference to dentists at DSO clinics, I think some people would think that you're talking about the practice of dentistry in a clinic, in a DSO clinic. I'm just suggesting that you might want to not use that phrase unless I'm still not understanding what you're saying. But you're talking about a DSO model, you're talking about support services.
Correct.
But when you reference a DSO clinic, I think it leads to some confusion.
Well, in the instance of Kool Smiles, our offices are Kool Smiles, and that's the clinical division of our company. The DSO that supports Kool Smiles is NCDR, LLC. But there's a clear distinction between the business support and the clinical delivery of care. But I understand your point, and I'll certainly make note of that. I appreciate it. Thank you so much.
Representative Laubenberg.
Okay, and just to try and clarify that as well, as Dr. Black said, a lot of these new dental students, when they graduate, they have a lot of loans. You know, it's very expensive to set up a practice. So maybe 3 or 4 of them go together and say, let's do something together. And so they would contract with, say, Kool Smiles. Y'all would provide the receptionist, provide some of the expensive equipment, find the location. Is that what you're saying? I mean, they're the ones setting up the practice, but you're taking the expense of the overhead?
All right. Well, I know it's a little confusing because we've heard a lot going on regarding this. This is the best way I can explain it, and I hope it's appropriate. But Kool Smiles is the delivery unit, and that's our offices are called Kool Smiles. We hire doctors, be it private practice doctors who have been in private practice coming to us now working, or it could be new dentists coming right out of dental school. So Kool Smiles hires doctors to work in our offices.
Okay.
The business support services, which is the DSO support model that provides the business support for the doctors in our offices. So
okay.
We hire individual dentists who work independently, who work.
So when they're independent, now let me ask you, is this what folks are talking about when they say you have investors investing in Kool Smiles? Is that part of it? Is that kind of where some of the gray area is?
I can only explain it to the extent that says that in an investor group.
They're not investing in the dentist, they're just investing in the
support services.
The support services, okay.
Correct.
But the dentists themselves.
I would see that as simply as like a bank. When a private doctor goes into business and they get a loan from a bank, it's a similar model of that.
Okay. But the dentists themselves.
Correct.
There are not staff meetings where someone is saying you need to do X number of cavities today and you need to do
Absolutely
X.
not.
Okay.
Absolutely not.
Are there any kind of reports where the dentist fills out to say here's what I've done?
No. All decisions that are made by the dentist are based on medical necessity of care. There is no report or no quota that our doctors have to meet.
Okay.
It's strictly based on medical necessity.
Representative Guerra.
Yes, thank you, Madam Chair. I kind of look at things maybe a little differently for me to understand issues. Let me see if I understand, because there seems to be a dichotomy. Well, let me see if I can explain.
Okay.
I know that there are physicians and there are dentists who have their own practice, but they want to focus on patient care. And so they will contract with a separate company to come in and help them with the administrative aspects of a practice. But at the same time, that dentist or that physician still owns their own practice. So if that practice, be it dentistry or an MD, is not doing so well that month, that dentist doesn't make so much money that month. And if that dentist or that physician makes more money the next month, then they make a little bit more money the next month. And that makes sense. There are lawyers that do that. They want to focus on just practicing law, but they still own the practice. Let me see if I can simplify this. Are the dentists that work in Kool Smiles salaried, or how are they paid? And the second question is it their own practice, or are there shareholders that own Kool Smiles that are not dentists? Because to me, that's a big distinction. A dental group who are all dentists and they own their own practice, but there are no non-dentists that own the business or the practice. as opposed to an organization that there are shareholders out there who are not dentists, and they're also making a profit off of the money that's being made at the end of the day. So I'm a little confused. Maybe you can crystallize it for me.
I'll try. Our dentists receive base salaries. So that frees the dentist from having to work for commission. So our dentists are hired to work at Kool Smiles. They're provided a base salary. This allows them to concentrate on the patient's needs and provide the services based on medical necessity without having to worry about how much they'll be paid the following month. And that, I think that's what is the strong point here, is that when a doctor is having to make those decisions, and in fact, I was a private practice. I had private practice myself. And I absolutely understand that when you take a vacation, the money stops. And one of the beauties with our model is that our doctors are paid on a base salary, so that their decisions about medical care are just strictly based on medical necessity.
Well, but answering the question as far as who owns Kool Smiles, are there shareholders out there that are not dentists?
Kool Smiles is owned by dentists.
Okay, but is Kool Smiles part of another entity or a?
We're supported by the DSO, which is our NCDR.
And when you say
LLC.
Supported, what does that mean?
It just means that DSO provides the business support for Kool Smiles offices.
And are there separate shareholders that own that?
The owners of Kool Smiles, they do have an ownership in the DSO model.
Who are not dentists?
The dentists who own Kool Smiles are dentists, and they're licensed in the state of Texas.
Well,
But they do have ownership as well in NCDR.
For any other lack of term, subsidiary, is it kind of like a subsidiary? I mean, I'm trying to understand what this relationship is.
Okay.
You said like a bank.
Well, Kool
Underneath.
Smiles is the delivery system. That's our doctors work for Kool Smiles, and
Okay.
Okay.
Let me write in here.
I'm sorry.
I know you've even come to Brennan to try to
Yeah.
explain, so let me see if I can help out.
Thank you.
An excellent line of questioning. I don't think you're a freshman, okay? You've served in some other state somewhere else, so congratulations. The statements that you make is that Kool Smiles hires dentists.
Yes.
That might be a little bit nerve-wracking for the people up here, because the fact is that we like to think that dentists actually get their degree, they get licensed, and they go out, and they may hire a dental service organization to help them, but they're not necessarily, and I know what you're trying to get at. Let me see if I can explain it. You do have your company that does have stockholders in it, okay? And that is, what's that? It's got a bunch of letters in it.
NCDR LLC.
Okay, NCDR. And they have stockholders, and I guess it's private equity, or it could be straight on the New York Stock Exchange.
It's private equity.
Okay. So there's stockholders there, Representative. And what I best understand is that they have models out there that they, I think even if I read the story correctly, at one point they were going to buy other dentists out, but then they decided they could just grow their own. But they go and they own the buildings.
Correct.
And they basically pay them a salary to go in and practice medicine, and they do everything else. So that the dentist there that works for Kool Smiles is supposed to be, under Texas law, the sole decision maker.
Correct.
Okay?
And that's the
But
distinction.
everything around them, and I guess this is where we get to the corporate practice of dentistry, where my father was a dentist who owned his own chairs and his building and all that good stuff. This is different. It's kind of like I am a salaried person that goes to work
For the company.
for the company. Now, doctor, with all due respect, this is what we have to decide in the state of Texas is if we want to, as policymakers, we want to keep going down this road. Now, you're a very nice person, okay? and you're doing a great job. But it just happens to be a story from PBS on Kool Smiles. And I would think that this would raise a level of maybe awareness for us and maybe caution. I'll just read parts that I highlighted in this.
Madam Chair, just for the record, I haven't seen that.
Yep.
It was just, when I was listening to the testimony.
No, I
was very confused.
Yeah, you went straight to the matter. So let me tell you some of the things that I think have been seen in other states. It goes through that nearly half of the nation's children were on Medicaid or similar government assistance last year, yet even with this insurance, families in poverty often struggle to find a dentist of their kids, forcing them to use emergency rooms to treat toothaches. And we all know that that's a problem, right? To solve that problem, instead of a lawsuit, the state of Connecticut dramatically increased the fees it paid to dentists through Medicaid 4 years ago. That sounds familiar to Texas. Everybody agree? A flurry of private dentists signed up, and soon corporate dental chains specializing in Medicaid began opening offices around the state. One of them was Kool Smiles. The Atlanta-based chain is the largest Medicaid dental provider in the country, serving roughly 2 million children with 129 offices in 15 states and the District of Columbia. Goes through, talks about different examples. It said the state started requiring dentists to get prior approval for each crown. That's when the state identified problems at Kool Smiles. It talks about the problems discovered in Connecticut have shadowed Kool Smiles elsewhere. A joint investigation by the Center for Public Integrity and Frontline found the same business models that make Kool Smiles profitable as a dentist of last resort has also led to complaints that they provide unnecessary treatment for children in need. Medicaid pays an average of 30% less than what typical dentists charge, the company says. So Kool Smiles acknowledges that it has to be more efficient than most dental offices and has developed a computerized system to track its work. Several former employees said the chain is highly focused on production and offers bonuses to dentists who bill beyond a certain amount, and in some circumstances will fire dentists who fail to meet production standards, according to internal and court documents, as well as former employees. I skipped down to say in Texas, a child under the age of 9 at Kool Smiles has nearly a 50-50 chance of getting a crown as a restoration to treat problems like cavities, our analysis found. That company, that compares to a 1 in 3 chance on average in other providers. And in the end, I'll just read this last paragraph. NCDR is known at Kool Smiles for meticulously tracking data. The company distributes an office scorecard each day, showing each office monthly and even daily ranking of how well they met revenue targets. The scorecard from September 2009 showed that for the month, 34 offices hit their target revenues while 24 did not. And the story is a very long piece. And I don't mean that aimed at Kool Smiles. This piece was aimed at Kool Smiles. Not long after that, y'all came out with the Laffer report. So I know it's quid pro quo on, this, that, and the other. But I think that just in that article, with a line of questioning from a new member, with a line of questioning from very senior members, there is concern. You've heard the Attorney General say that there is concern that, and I paraphrase, that he said it seems like private equity, some of their major problems have followed private equity type dentist practices. And so with that, I won't make you sit there and defend it. You know about the PBS article and the troubling data that has come out of that. And so as we move forward, I think the duty of this committee and like committees in the Senate are going to be struggling to strike that balance where we're trying to serve a needy population, but we're trying to do it in a way that is consistent with the dental practice and not be a party to scorecards that incentivize. I mean, that's just not what we view dentistry. I may be speaking for the whole group here, but I'm not sure we view dentistry in that regard.
Madam Chair, you know what? I mean, listening to all this today, it seems like the responsibility still resides with us. We're the ones handing out the dollars. And you keep bringing up SPRU and the...
A lot of money.
And, you know, we found that we had breaks in the accountability chain within our own agencies. And, you know, we went a pound, which absolutely go after those who are committing fraud, no doubt about it. But if we were more on top of our game, we might be able to stop a lot of this. And, you know, my concern is, you know, we keep swinging this pendulum back and forth, and at the end of the day, we're going to have fewer providers and less access for those legitimate children or, you know, those in need. So I still say we have to keep pointing the finger back at us.
Yeah, I think that's well said, and hence, you know, with both the waiver and this dental matter, we're not far away from a 12-hour hearing at this point.
Yeah.
And I do think that's why and I thank all of you for staying, and for those that came today in any form or fashion or are listening because they couldn't be here today. This needed a lot of attention, you know, both issues. Right. And when we get into session, it's fast-paced, and everyone wants their bill passed, and everybody's in a hurry. That's why I wanted to do it now, where you still have time to start thinking about legislation. What is our responsibility, Jody? And I think we have advocated it in many ways. But it's the balance of putting enough money in the system and making sure these children are served. But we certainly have attracted, and there are certain business models that seemingly follow these lawsuit settlements, and they go in and put lots of dentists on the ground.
Let's up our standards.
Yep. Okay. So, Doctor, thank you.
Thank you.
You did great. I can't. You're a very nice person, and I appreciate you coming here today. And then, yes. Sorry, Steve?
Yes, thank you, Madam Chair. I have a question about the LIFR report, and I understand that Kool funded that, his research, correct?
Correct.
And so it was saying that he had analyzed every single Medicaid claim for the fiscal year 2011 to the tune of 25.9 million procedures. Could it be that the way Kool defines a procedure is different from a fee-for-service dentist or any other kind of dental practice, because the numbers are so discrepant? And if people are accusing your company or your practice of overutilization or doing too many things, it's clear that not only the numbers of procedures, but the cost is probably half of the DSO dental offices or just other dental clinics. So was the same variable in defining a procedure consistent across?
I would think so.
But
Correct.
Do you know that it was?
I can only see that, you know, a dental procedure is based on individual billing codes, and I would think that the data that was utilized should have been based on actual procedures. The 25.9 million procedures would be the same procedure that we or individual dentists or even private practice dentists would bill specifically for.
And that's
Medicaid.
in 1 year.
Correct.
I have a question for HHSC regarding the Freedom of Information Act on the access to that. I wasn't aware that
Commissioner Trail?
any private entity can, I guess, access it. I don't know if they pay for it or what, but to have access to every single 25.9 million procedures. I don't know how many claims that's inclusive of, but through the Freedom of Information that a private entity can obtain that for their research. Is that common on just about anybody?
Yeah, it's not. For Chris Traylor, Deputy Commissioner, Health and Human Services Commission. It's not common for anybody to have client-specific data unless it's the agency or a contractor for us that's doing it for the specific use for the program. Having aggregate claims data is not something that happens frequently, and I can't say under what auspices it was obtained at this time.
Okay, who gives that authority? I'm wondering because it talks not only about the specific patient procedures, but also the number and also the cost. So that's pretty, and if you talk about 25.9 million, I was just wondering I have not heard that before in any research that we've had presented here or had access to see. Can we find out who?
We will.
Okay. Because it's a little bit coincidental that you can access that information. It's given, you can analyze it, separate out the data, and then give your report that you paid for. So it's kind of connecting the dots. I'd like to know more about it.
Certainly.
Yes.
Yes, Madam Chair, just very quickly, Dr. Earle, thank you.
Thank you.
I was asking those questions only because I was a little confused. I assure you I haven't read.
No, it was just my staff is very good researchers, and
I was just trying to understand what the makeup was.
Yeah,
So.
I hope.
But at the end of the day, you're making the clinical decision.
Absolutely.
Thank you.